Hello, everyone. Thank you for joining us on Day 4 of Health Equity Week of Action. Today, the topic of our session will be racial disparities and treatment and access. We are so lucky to have Ms. Aswita Tan-McGrory as our speaker. She serves as Deputy Director at the Disparities Solution Center. She's a key member of the senior management team and supervises the broad portfolio of projects and administration of the center. These include a collaboration with the Center of Quality and Safety at Massachusetts General Hospital to develop the annual report on equity in healthcare quality, which analyzes the key quality measures stratified by race, ethnicity, and language. She's also involved in the Boston Public Health Commission on developing and implementing a citywide Disparities Dashboard, and the Pediatric Health Equity Collaborative to develop recommendations on collecting race, ethnicity, and language from pediatric patients. Ms. Tan-McGrory also oversees the Disparities Leadership Program, an executive-level leadership program on how to address disparities. In addition, she works closely with the director to chart the Disparities Solution Center's future growth and strategic response to an ever-increasing demand for the center's services. So without further ado, we'll be hearing from Ms. Tan-McGrory on the topic of race and language in healthcare, the impact on quality of care.
Thank you for that introduction, and welcome everybody. So I've been asked to sort of talk about the impact of racism in healthcare, and so today I'll talk a little bit about stereotyping, what is happening nationally in the field of disparities, talk about the importance of monitoring and reporting, as well as some of the interventions that we've developed at Massachusetts General Hospital or MGH. So this is a picture of me, and I thought we could just be a little bit interactive and just sort of start with an activity. And so my question to you is, I want you to put on your clinician hat and, see me as a patient coming into your office, and what are some assumptions that you might make about me based on what you see? And so just take a couple of seconds and jot down, hopefully you have a piece of paper and a pen nearby, just three bullets of things that you might make assumptions about me based on what you see here visually. And I was kind of hoping for a super interactivity. We have a small group, so that's good. And so maybe if you've jotted something down, you can send some of your thoughts my way, our way, and I promise I won't be offended by anything you say. So feel free to use the chat box. Yep.
We have an individual stated Asian American. Are there any other markers or identities you guys can associate?
I like this. Probably a good diet. Okay. What are some other things that, as a clinician, you might make assumptions about? The first thing you see, Okay, we have a quiet group. Okay, you look like you're dressed professional, yes. You guys are being very polite. But that's good. I like polite clinicians. Okay, so I've given you, here we go, there's another one. Don't be shy. Healthy, okay. So I'm super healthy. You're thinking I'm probably not going to be a patient that you need to do much taking care of, right? You might see me for an annual. So what I was really trying to get at here is, let me move this aside, is, who am I? We make assumptions about the following based on what we see. And so what I have here is age, where I was born, my first language, my level of education, what I do for a living, my race, ethnicity, and my immigration status, and whether or not I'm single. Okay, I see here somebody I may have a variable grasp on the English language. So the point that I'm trying to make here is that when we see somebody, we make certain assumptions about them. We all do to some level, and it might be subconscious and it might not be conscious, but there are things here that we make assumptions about. And if you look at these things that I've listed, is, obviously sometimes people make assumptions about age when they don't know, because a lot of people, you can't ask unless, you have a reason to ask. Where I might be born, what might be my first language, how educated might I be, what might I be doing for a living, what is my race, ethnicity, and what is my immigration status. And if you think about this, this is really like an intake form, right, that you do in your head. It's very similar that you might, as a clinician, collect this information. And I'm realizing that my animation that I had built into my PowerPoint isn't really working, so you're going to see some answers before I really wanted you to see them, so bear with me. But there are some things about me that are not readily apparent unless I choose to share them. And so here's a couple of things that are not readily apparent. One is that I was a Peace Corps volunteer. I lived in Nigeria and West Africa, no running water, electricity for 2 years. I have 7 tattoos, so you can't see that when I have a suit on. I have 2 piercings. I'm fluent in Dutch, Samba Hassa, and I've studied Spanish, French, and Yoruba. English would be considered my second language, but actually it isn't my second language because I spoke a bunch of other languages besides Dutch, so it's probably like my third language. And I came to this country as an illegal immigrant. And when you think I like to always sort of raise this in these kind of discussions because in healthcare, a lot of these assumptions are tied to what we think might be outcomes or the type of care that we might provide to folks. Some other assumptions that are not readily apparent about me is that I was raised by a single teen mother. I was raised in a household with domestic violence. My brother is a meth addict, and 3 out of 4 of my siblings have a criminal record, and all have had issues with drugs and alcohol. So I always like to sort of, do this exercise because I think oftentimes we just take things at face value, and especially when you're sort of in a stressed environment where you're short on time, we make assumptions about people. And I will be honest with you, I've never shared any of this information with my primary care provider. And I've seen her for about, 15, 20 years. She doesn't know any of this information. But when you think about health outcomes and who's at risk, this might be important information for her to have. So it's just important for you to realize not only do other people make assumptions about your patients, you yourself might have some assumptions. And I think that's okay. We all do it, but to just be really aware of this. And when you think about it in terms of healthcare, then really what we're talking about is stereotyping. And stereotyping tends to happen most when we are stressed, when we are short of time, when we have to make quick decisions. It's something that we do mostly subconsciously. And so I'm sure all of you have heard about unconscious bias, and that is part of some of the problems that we're having in healthcare when we talk about health disparities. It's not all of the problems. A lot of them are systematic. A lot of them are about patient-provider interactions. A lot of them are about the health system itself. But if you think about it, the health systems are built by people. So stereotyping is a big issue and sort of at the root of the problem that we're facing in healthcare today, especially when we talk about disparities. So here's a survey that Kaiser did when they surveyed Americans on race, and this is really, I thought, sort of illuminating and a reminder, and it's not a surprise to many of us who do this work, but it still is like, oh, come on, we haven't really moved the needle on this. And so it doesn't come to a surprise that 35% of the blacks and 26% of Hispanics report personally experienced discrimination because of their race and ethnic background, or that they've, in the past month, experienced unfair treatment. And even worse is that 45% of blacks said they have been afraid of their life in comparison to whites and Hispanics. But what I think is the most important that I've circled here with the red dot was that, this second bullet, which says in the previous month, 53 to 36% of this, 53 of the blacks and 30% of Hispanics said that they've experienced unfair treatment in healthcare, in getting healthcare. So this is important for us to understand, is that for all the training that you could do in cultural competence and everything that you know, you have no idea what the experience is of the patient that comes to you. They might have already had horrible experiences either, on a daily basis or previously in healthcare. And so sometimes, they're already coming to you with something in their background that you had no part of and that you might not know about. So we have to be super aware and super thoughtful about some of the assumptions that we carry around with them and that we might make about people, and really be aware of them. If you think clinicians don't have any biases, I found this other report that just came out, Medscape surveyed physicians on burnout and bias, and they said, do you have any biases towards patients? And look at this. I think it's amazing, actually. I think it's amazing that they even answered this. But, the largest number of, the largest percentage was found in emergency medicine, and then, family medicine and OB-GYN are pretty high up there as well. And then I think when you get a little bit more in specialty care, the folks are saying I have less bias. Now, this is, of course, you have to take this with a grain of salt, because we're not talking about unconscious bias. And these are people that say that they have bias, but we're not really counting the unconscious bias in. I think what is interesting about this is that, where do we know that minorities get probably the most care is, they're more likely to be getting care through the emergency medicine. You're more likely to see them here in family medicine, and I'll show you a slide about that, about where we see minority patients at MGH in just a second. And then here's another slide with this data where they said, so what patient characteristic triggers bias? And no, race, interestingly, is at the bottom, but I think you and I probably know why it's at the bottom, because I think it's a touchy subject and people aren't really going to admit that that's something that triggers bias. What I thought was very interesting when I looked at this from the perspective of the work that we do, and that's something I'll talk a little bit more about later, is language difference was pretty high up there. So having a patient, and this probably doesn't come to surprise to you guys, is that if there's a patient with limited English proficiency, they're more likely to have bias towards them. So then if you picture this with emergency physicians, right, ED physicians, your patient comes into the ED, it's a crisis, and there's more likely to be biased, and then they don't speak another language. You can sort of see the scenario that I'm painting, and we just need to be aware of that. So here I have a slide from our annual report on equity and healthcare quality. We do this every year, and some of the data that we look at is like, where do we see minority patients at MGH? And so I'm going to sort of see if you guys can figure out what are some of the trends you're seeing here. And feel free to send me something through the chat, or send it to everybody if you can. Lots of Hispanics in the outpatient primary care setting, yes. So where are you not seeing them? You're not seeing much in inpatient care. You're seeing a lot in the emergency department, right? So this is something actually our VP of Community Benefit always says, and when we look at the distribution by specialty, we see a lot of minorities in pediatrics, in OB, but not so much in real specialty medicine. And I think that's probably has to do a little bit with also access, but also it has to do with, engagement in healthcare. So when you go back to that slide where you see physicians who say they have bias, it sort of aligns very nicely in that where we see a lot of minority patients, also physicians have a lot of bias, although they say they don't have a lot of bias for race. So I think all of you know what disparities are, but I like to just always sort of at baseline give a definition. Disparities are really gaps in the quality of health and healthcare due to differences in race, ethnicity, socioeconomic status, sexual orientation, gender identity, and or ability. So when I ask when I'm asked what I do for a living, it's always tough when I'm talking to somebody who's not necessarily in healthcare, or even if they're in healthcare, not in disparities, to explain what disparities are. And I actually do always sort of cite this study where they did a study in the ED, and they looked at patients who either came in with a broken arm or a broken leg, and they found that if you were African American or Latino, you were less likely to receive pain medication than a white patient, even if everything else around access, insurance status, and education was the same. So once people are always sort of shocked by a statistic, and because of the nature of the work that I do, I'm like, really? This is shocking to you, given the historic background here in the United States that continues, to be the forefront of the news. We know here I have the two reports from the Institute of Medicine. We always reference these as our reports. In 2002, Unequal Treatment came out from the Institute of Medicine. Our director, Dr. Joseph Betancourt, was actually on this IOM committee that put this report together, which basically said, yes, disparities exist, and it's a variety of factors. Some of them are health system factors, some of them are provider-level factors, and some of them are patient-level factors. But there is no one cause and no one solution. And then we have the crossing the quality chasm, where really this report talks about quality and the 6 pillars of quality, and equity is one of the 6 pillars. And so, part of quality is really providing equitable care, and that's really sort of the angle that we've taken here at the Disparity Solution Center. Unfortunately, even though the report came out in 2002, here there's a slide from the National Healthcare Quality and Disparities Report that comes out every year. And what this shows you is whether disparities are getting better, if they're getting worse, or if there's no change. And blue means there's been no change. And so unfortunately, we haven't really seen any change in any of these. Because if you look at poor versus high income, there really hasn't been any change in disparities. Black versus white. So I would say, even though the topic of disparities has been around for a while now, over a decade, at least if you count it since the IOM report, we're not really moving the needle here, and it's complicated. And so I wanted to just go back and sort of talk a little bit about, there is this growing multiracial population. And here, what I have here is a slide of my family and where we come from. So as I told you, I was born in Holland. I'm actually Dutch Indonesian, and in case you're curious, I'm 44. I came to this country when I was probably about 13, and then, sort of fast forward, I met my husband in Boston, and he was born in Ireland and came to this country also as an undocumented immigrant, and we met in Boston. And so our family is this concoction of sort of Dutch, German, Indonesian, and Irish descent. So we are very much a bicultural, bilingual household, and that's a growing household. And so this is a case study of my daughter, my oldest daughter, Norelle. She is now 9, and we do a lot of work sort of in data collection, and one of the reasons I always bring her into this conversation is because when she was about 7, she turned to me, and I was doing all this work in data collection, and the gold standard for race ethnicity data collection is to ask the patient, and she said to me, "Mommy, I'm Irish." And I said, "Well, okay, wait, that's part of you, but actually you are also Indonesian, you're also Dutch." And she was very strongly said, "No, Mommy, I'm Irish." And I was like, what's happening here? And then I thought, well, okay, wait, this is interesting, because if she was going to fill out the demographic piece as a patient, or really for anything, she would mark, "I'm Irish." If I was going to fill it out for her, I would mark she's Dutch, Indonesian, German, whatever category I would fill out. But for her, it's very different. And then when I thought about it some more, I said, well, that makes sense. This is a picture of her with her cousins in Ireland. At that time, for her, being in Ireland is just a fantastic experience. She's a city kid in Boston, and when we go to Ireland, it's great. She has all these cousins. They live on a farm. There's sheep, and cows, and she runs around, and you know, she has a great time. And even in Ireland, in Boston, being Irish is great. St. Patrick's Day, you know, we have parades. We, you know, go to a bar that my friend owns, an Irish bar, and there's Irish dancing, and everybody brings their kids. You know, she gets to wear green stuff. So you can see how, from the perspective of a 7-year-old, being Irish is just great. And there's a lot of affinity, and therefore she says, I'm Irish. So it really made me think about sort of this assumption that even I made about my own daughter's race and ethnicity and how she would self-identify. That's very different. And then in addition, I'm trying to move this slide. There we go. Here's my other daughter, Annika, and she's 4 now. And so I thought about it. I thought, well, I don't know yet, you know, what her answer would be to this, but I could possibly say that it might be different. You know, so even though my 2 daughters were raised in the same household with the same parents, they might have a very different experience about how they view themselves. And so we have to think about these things, and this is why it's important to ask. And I think when my daughter gets older and she says to people, I'm Irish, somebody, especially in Boston, who, you know, is from Southie and whose great-grandparents came over from Kerry might say, you're not Irish, you don't look Irish, you know, I'm Irish. And so things might change as she gets older, right? She might decide that maybe she's not going to identify as Irish, she's going to, you know, be more like, okay, maybe I'm Dutch Indonesian. So I think race it's so important to ask the patient always. So I'm putting up here the race and a definition of race and ethnicity, because I think there is still confusion for folks, especially patients who are not doing this work. You know, why are you asking me this question and what's the difference? So race is really sort of a category of, and I took this directly from the Merriam-Webster dictionary, the category of humankind that shares distinctive physical traits, whereas ethnicity is more your background, your heritage, culture, and ancestry, so being a member of a specific group. Now here is the Office of Management and Budget, and what we call OMB Categories, and this is probably the most commonly used categories across in the U.S. about race and ethnicity. This is sort of the gold standard, not because it's great, but because the government came up with it and nobody has really offered up anything better. And the reason I say it's not great is because when you look at these categories, where would you put my daughter, and really how granular are we getting here? And sometimes, you know, you can only select one. So I think all of you have probably seen this at some stage on some form. And so it's a real challenge. But this is still better than nothing. Okay, here we go. And so we have a growing multiracial population. My daughters are not unique. So even as we struggle to fill the OMB categories incorrectly, and they definitely don't address some of the diversity that we're seeing. And as you can see here, there's a 33% increase in the number of people who identify as multiracial. What's even more interesting is that the number of children who identify as multiracial is growing even more. And in part, this is probably due to the fact that the percentage of interracial marriages has doubled in the past 30 years. So I also think in part because we are doing a better job in collecting this race ethnicity data. And data is important because without data, you don't know how you're doing, right? You only know half the story. And here is another sort of projection where they looked at the U.S. Census and they said, you know what, minorities are going to outpace whites pretty soon in 2050. So that was the projection. So whether we like it or not, we need to figure out how to provide equitable care to minorities, because pretty soon minorities are going to be the majorities, and this has a huge impact on our healthcare system. When we look at the child population, it's actually sooner. By 2020, they're projecting that minorities will be the majority. So it's important. These, you know, this is everybody needs to get at the table. And then when we look at the newly insured population of 30+ million folks who, you know, were added in thanks to ACA, what we know about them is that they're more likely to be a minority, they're less likely to speak English, and they're less likely to have a college degree. So there is an incentive for us to really figure out how to fix our healthcare system. This is, I actually didn't put this up so that you can read all of it, but I wanted you to get a sense of sort of how complicated it is in this country even to collect accurate race ethnicity data. This is a project that we did for the Centers for Medicare and Medicaid. And basically we did an overview. This is a process map of how CMS collects race ethnicity data, and you can see it's complicated. But what I want you to focus on is, let me see if I can use this pen, is this part right here. So after all of the stuff that happens on the left of where the different sources that they get the data and, you know, all the different categories, where CMS ends up is the categories that they have is just white, black, other, and unknown. It's so crazy. When we put this together, I was like, oh my God. And so then they have all these other complicated ways that they sort of backfill the information in. But I want you to understand, the reason I put this slide in here, I want you to understand that even the government isn't, you know, doesn't quite have a handle on this. It's really complicated. And so sometimes the data is not great. So this gets me to the next point, which is, you know, monitoring our performance at MGH and developing interventions. It's so important that you have the data because the data is going to tell you how you're doing. So we're very fortunate at MGH. We've been putting together this annual report on equity in healthcare quality, and we've been doing that for 7 years now. It's actually available on our website. We're probably the only hospital that made it public. It's a, I don't know, 40-page plus report. It takes us a year to put together. And really what we do is we monitor disparities within our healthcare system, and we take core quality measures and stratify them by race and ethnicity, but we also have some disparity-specific measures. And what I mean by that is that we take measures where we develop measures based on where we know disparities exist. So I'll talk about that a little bit more in a second. But we've done this work for a while now, and we've received some awards for this work. One is from the the AMC, we got the Challenge Award, and then from American Hospital Association, we received the inaugural Equity of Care Award. So this has been a great acknowledgement for all the work that we do in this space. And so here's the contents of the REC report, which we informally call the Disparities Dashboard, is that we look at all previously reported measures, stratify them by race, ethnicity, and language. But we've also looked at department-level measures. So for example, in pediatrics, we looked at asthma because we know that there are a lot of disparities in asthma. So we tried to figure out, okay, can we look at our patients and see if there's any disparities there? And then we are also looking at caring, you know, for patients with limited English proficiency. So I'll talk a little bit about that. What this report has allowed us to do is to figure out where the gaps are and what we can do about them. So this is sort of an old project, but we saw that the hemoglobin A1C levels, the control of hemoglobin A1C levels were not as good for Latinos as they were for whites. So we developed a navigator program, and we hired a bicultural, bilingual navigator that helped patients in managing their diabetes. And so as you can see, what happened is the program was open to everybody, but it was targeted towards Latinos. And what happened is that things improved for all patients, both whites and Latinos, and the gap narrowed. So we were able to do that. It was a very successful program. And we did the same thing with colorectal cancer screening. We had lower colorectal cancer screening for Latinos than we had for white patients, and so we put in a navigator program, and that person helped the patient sort of understand why they had to have screening and accompanied them to the appointments and helped them. And so we actually increased the screening rates of Latinos when you compare them to all other practice. Chelsea is where we had the navigator, but it went up overall for everybody, so that's the great thing. We know that when you look at patient safety of patients patients with limited English proficiency, they are more likely to have adverse events and more severely. They're more likely to experience medical errors, and they're more likely to suffer physical harm. So when you look at this, and when we looked at some of our data in the dashboard, we saw a lot of disparities by language. So we decided we wanted to do something in this space. And one of the things actually that we did is we developed an e-learning program. And we did this for medical students and nursing students because we had actually developed previously before that a toolkit for hospitals, and it's called the Team Steps Toolkit, where they can sort of learn about how to work better with an interpreter. But we realized that we needed to get this information to people before they are already in the hospital, and so targeting medical students and nursing students. So we developed this e-learning program. It's actually available on our website for free. You can download it, and there's 3 parts to it. The first part sort of talks about what is the system problem. The second part talks about how to better work with an interpreter, and the third part is, what can you do about it? So it's been a great program that we put together. And actually what we did, I'm just going back to this slide. One of the things that we did is that when we worked with the OB department, we realized there were some differences and disparities by language. What we did is we took the part of this module that says, how to work better with an interpreter, and we rolled that out as a pilot to all the OB physicians and midwives as part of sort of how to address this issue about these differences that we see that we think might be because patients are not seeing physicians with interpreters. So a continuation of some of the work that we did is that when we developed this e-learning curriculum and students went through it, I think we said, well, how do we know that we've provided them, with enough sort of information? When people become residents, what is sort of the hidden curriculum as it relates to providing patients with LEP care? And so it's all well and good if you educate folks on how to better work with an interpreter, but what if your attending doesn't want to use interpreters because they don't have time for interpreter when they see patient? What sort of messages are we sending here? So Dr. Green, who led this project, he's a senior faculty at our center, he really wanted to do some work and do some qualitative interviews with students to find out what they were seeing, develop a tool, and then pilot this tool. I think what is interesting probably for you guys is that some of the major themes that came out of this qualitative study that they did, and probably none of it's really surprising to you, but they talked a lot about role modeling. It's very important that providers demonstrate this empathy and dedication. But what wasn't great is that they were not involving interpreter services. And so going back to this, the earlier slides of bias and what triggers bias, I think in part for language is people have this perception that when they have to involve an interpreter in a clinical interaction, it's going to take more time. They've actually done studies to show that actually it doesn't take more time and it improves the clinical interaction. So it doesn't actually, if you've done correctly, it doesn't take more time, but that's oftentimes folks do not have the time to do that. And sort of, role models work with interpreters but lack empathy for patients with LEP, I think, is another way that, these sort of hidden curriculum messages that were happening. And then, of course, there are the structural challenges. At MGH, we have actually a very robust interpreter system available. It's both in-person, phone, and video. But, limited availability of interpreters, lack of training awareness among staff, like how to access them, how do you get the phone in, and we call it the iPop, which is interpreter phone on a pole. And literally you bring it in on this little pole that you wheel it in, and you pick up the phone and you can speak to an interpreter. And I think one of the biggest pieces that we're working on is that in our electronic medical record, there's no way to indicate that a patient is a patient with limited English proficiency and needs an interpreter, and there's no way to record whether they received an interpreter. So even when we stratify the data and look at disparities by language, you know, the next step would be like, well, okay, are we seeing these disparities because, for example, at discharge, this patient didn't have an interpreter? But we can't really do that because our electronic medical record doesn't have the capacity, and we're hoping to change that, but, you know, these are just structural challenges. And then there's the organizational culture, which I think all of you are probably familiar with, is time and efficiency is valued more highly than communication. There's a lot of pressure, and there's also just sort of thinking about, you know, the organizational culture. You're obviously not going to tell your attending that he's doing something wrong. And students are evaluated on clinical knowledge more than empathy and communication with patients. So I think this is an interesting project, and it's still ongoing. But here's sort of a summary slide. You know, we really need to, I think for me, the end game is that we need to focus on how to change the culture early. And that obviously by the time students are trained, then they get on the floor, there's sort of this hidden curriculum, and we need to address that as well. This is our website, and if you go to this website, you can see a lot of the resources that I mentioned, the annual report. Actually, it's under programs, annual report on equity and healthcare quality is there. Under resources, we have that module that I talked about, the e-learning module, if you're interested in that. So I just wanted, in summary, sort of an overview. I think what's important here is that, you know, you create awareness, both self and for others, about, you know, some biases or stereotypes that you might be carrying. Clearly, it's still in existence. I mean, I love this, like, latest survey. I'm actually surprised they were able to get physicians to admit that they're biased. And you know, leadership includes being able to address the business operational side of things. I always put this in because, you know, for example, we want to do right by patients with LEP, but we realize all of a sudden, wait, we can't do what we'd like to do or pull the data that we want to do because we don't know what the capacities of our EHR. So, you know, just thinking about not only sort of, you know, having a, not only, you know, knowing the focus and the disparities need to be addressed, but also sort of addressing, like, you know, okay, how do you implement it? How do you move this forward? I also think you shouldn't underestimate the value of data or personal stories. Personal stories resonate with people quite a bit, and so I always like to have a balance both of data, hardcore data that people can respond to, as well as sort of personal stories. And then when you do this work, it's really important that you remember why you went into healthcare or public health in the first place. You know, tap into sort of, even for myself, you know, when you look at my background, I think, you know, of all the things that could have happened, if you look at that last slide, you know, or as my mom was a teen mom, you know, I grew up in a house of domestic violence. I mean, people will make assumptions if that's all they know about you, about where you might have ended up. So I think it's important that you think about why you went into healthcare in the first place, and use that in sort of your daily work. And you know, don't be afraid to be vulnerable, but be strategic about how you share that kind of information, especially when you're thinking about disparities or working with patients who are from underserved populations. So, you know, I think we do a good job here in our culture, sort of, you know, being very differential to a provider. But I will tell you that, you know, for most of the patients, it's intimidating if you are the provider and you know, you're not sharing some of your sort of personal stories that a patient can relate with. I think if my provider had, you know, maybe been a little bit more open and personal about herself, that I might have shared some of my background with her. And that might have changed some of the care that she might have given me. You know, it's hard to know, but with fewer patients, definitely, it's difficult to be in a room with somebody that you know, respect because of the position they're in, but how are you going to share with them important information like, you know, domestic violence in the home, or an alcohol or drug abuse problem, or even the fact that you're homeless. So you have to be vulnerable, but be strategic about when you share that. You know, don't just, you know, open yourself up for everything. So I'm going to stop here. I've talked enough, I think. 40 minutes was enough for me. So I'll stop here and see if there's any questions.
Great. Thank you so much for that fantastic presentation, Ms. Tan-McGrory, especially sharing your personal narrative and talking about programs that your organization has put together to close the gap on disparities. It's some really fantastic work. So we can open up the floor to any questions. If anyone wants to send any questions to me, and I can read it out loud in the Q&A function or through the chat function, you can send it to everyone. We'll take a few minutes to take questions. So I can get started. As I'm about to go into my clinical years as a to-be third-year medical student, I was wondering what advice you have for us in terms of countering our own personal biases. Is it how would you recommend that we counter that and accept it, recognize it, and then work to see beyond that?
Yeah, I think it's a good question. I mean, beyond what I always say is just be so aware. I mean, everybody has biases. I have biases. But just be aware and check yourself before you make assumptions about something. Is this really what is happening? And oftentimes I think it's just taking that extra step to look under the hood. If you think about a lot of the case studies that they demonstrate where, a patient presented as one way, but then they found out there was something completely different, really the defining moment is that someone took the time to not sort of take things at face value, but really take that extra step to ask another question, or expand the picture to figure out what is the home situation like. So I think that it's tough because you're in the system, and even with all your good intentions, you're going to get handed the way things are done for the last 20 years. So change is difficult in healthcare, and I recognize that. But I think just being aware that you have these biases, that other people bring them to the table, and also to call people on them. I think it's really difficult. It doesn't have to be like, I'm going to call you out in front of 10 other people, but you can always process it with somebody. So not really calling it out, but taking somebody aside and saying, I heard you say this, and I just wasn't sure, what that meant, and can we talk a little bit about that? And then oftentimes people realize that, that was not their intention, but how it came out was not so great. So I think that would be my suggestion, and to be open. I think there is this emphasis on memorization and learning all these things, and so we forget the empathy part. But I will say sometimes the best doctors are those that just listen. And maybe they don't provide, what we consider excellent clinical care, but the patient feels amazing because they really feel there was some engagement there and some listening and no judgment.
Mm-hmm. How have you seen there been any changes in related to the Affordable Care Act being put in place?
I do. I see more emphasis on data, which I think is always a good thing. So there's been a huge, with ACA, I've seen a huge emphasis on, one, electronic medical records, implementation of them, and two is this collection of data. And I think that's important because, hospitals may say, well, disparities don't happen in my backyard, but you don't know unless you actually measure. So forcing organizations to collect race, ethnicity, and language data and other data, so social determinants of health data or LGBT data, all of that has actually sort of increased since ACA. So that change I have noticed, and I think that's a good thing. The downside is that, it's been challenging to keep disparities on sort of the front and center of what is happening in healthcare, because I think organizations are scrambling to meet all these demands, such as meaningful use and now this, value-based care, so it's not fee-for-service anymore. But if you think about it, it makes sense that we focus on disparities because that is not value added, right? When we think about who are more likely to readmit, it's minorities. So why are they more likely to readmit? Well, most likely because something's happening once they leave the hospital. We've been doing a lot of work in readmissions by focusing on discharge instructions and all these other things, but all that falls apart if you're sending the patient home to an environment in which they cannot recuperate, and so they bounce back into the hospital. And so hospitals are realizing that they have to expand their focus, and so they can't just focus on discharge instructions. They need to start thinking about what are the factors that they might not necessarily have control over, but that still impact whether folks are readmitting, and therefore that will result in a penalty from CMS.
Mm-hmm.
I have a question.
Sorry, we have one. Is someone else speaking?
No, I have a question here that I got from through the chat. I don't know if you could see it, but it says, do you know, from Annie, do you know if there are any correlations between more diverse medical schools and cultural proficiency? That's a good question. I will say the answer to that is not. I don't think there's a direct correlation to having more diverse medical schools. Yes, I agree that we need to improve the pipeline and have more. We definitely don't have a diverse provider population. But I think more importantly, you have to look at the leadership in the hospital. And what does that look like? And despite all the pipeline programs, we're still not seeing a lot of diversity in leadership positions. So I think getting a more diverse student body in the medical schools is the first good step, but the people that are making the decisions are in large part male and they're in large part white. And what was interesting, as one of my colleagues pointed out to me, is that in academic medical centers, this is particularly very much leaning towards, non-diverse leadership. And I think in part that we were trying to figure out why this would be, and I think in part this is because when you think about academic medical centers and teaching and research, they attract a lot of researchers, and I think in order to be an MD or a PhD that's doing research, you have to have a certain skill set. I mean, I don't know that many, folks that are poor that are growing up and saying, oh, I want to be a researcher. So you have to have a certain skill set, and it has to start early. It's not something you can sort of wing towards the end. So I think that, where there's a lot of research being done, you're also seeing probably a lot of more white doctors and less diverse doctors because of what's happening in our education system from, kindergarten through high school.
Awesome questions. Another participant submitted, I'm interested in health disparities related to infant mortality with minorities experiencing the highest rates. What do you think accounts for these disparities? And what kind of work is the center doing on this?
We are not doing anything on infant mortality, but you're right. There are a lot of, actually for African Americans, there's high rates of infant mortality. And a lot of that has to do with, again, things that happen before people get to the hospital. It's prenatal care, but also postpartum care and the care that happens in between pregnancies and how often people have pregnancies and access to healthy eating and nutrition and support. So I think there's a variety of factors that account for the disparities. I will recommend, we have a colleague here, her name is Allison Bryant, B-R-Y-A-N-T, and she does a lot of research in the OB space on infant mortality, so maybe take a look at her articles, and she's done some interesting work on that. But it's a variety of factors, and I think, they haven't really been able to crack that yet because I think this is really about social determinants of health. So that's really complicated when you think about that. I mean, I actually think somebody asked me, do you think that, I thought this was like a great question, but I was like, really? They asked me, do you think that we will eradicate disparities? And I was like, no, not until we fix our educational system. Because I really think that when I go to schools and I see that kids are not getting a fair shake, that, they are not getting a good education. I don't even know how a kid that is hungry can study. And so, but we can't fix disparities if, from education-wise, we can't even provide an equitable education where people can get better income, and then take better care of their families. So I think the roots are so deep in our society, and the problems are so deep. It's going to, I'm not going to be out of a job in 10 years. I'll say that, and that's unfortunate. It's unfortunate.
Mm. Do you have any final words or recommendations for us as to-be health professionals?
I think this is a lot about self-examination and sort of turning the mirror onto yourself. I think it's overwhelming to think about what you can do when you think about what might be the root causes of disparities. And so, I think the only thing you really can change immediately is yourself. And so maybe, thinking about engaging in other ways, like who do you hang out with? Are you hanging around with a diverse crowd? And if you're not, why not? Take a look. I mean, the quickest way to figure this out is to look at, I don't know if you guys have a Facebook page. I think that's like more my generation. But, you look at people's Facebook page, you can quickly figure out, are you hanging out with a diverse crowd? Because a diverse crowd adds to your level of knowledge of sort of diverse, cultures and backgrounds. And so I think that's a quick way. And to just, create some awareness about what some of the challenges people might face that they will not tell you about at first blush. Just because you're a physician, nobody's going to tell you this stuff. And so figuring out what are the right questions to ask and to observe, when you're in the healthcare system, what are some of the issues that you're seeing repeating time and time again, and where can you help? So I think also, doing something, I know you don't have time, but this is really feeding your soul, doing something, whatever small it is, to alleviate someone else's suffering, whether that's volunteering, 1 hour every 2 months doing something, or helping out, a colleague in some way. I think, we need to take time out to create empathy within our life to also be able to relate to other folks. I don't think we spend enough time in medical education on empathy, and I think empathy in itself is very healing. I'm sort of starting to sound like some hippie guru, but I think it's true, I definitely know that when I have a good interaction with my physician and I feel that I'm being listened to, I walk away from that interaction really happy, and my patient satisfaction scores will be better. It's not because, my test score was amazing. It's because of the one-on-one interaction, and you have to remember that and remember why you went into medicine in the first place.
Well, we're going to close up right now, but thank you so much. Your insights were really inspiring, and we hope to carry these lessons forward in our training and in our career. Thank you to all of our participants. Yep, we have some students calling in saying thank you. So again, thank you for your time and putting this presentation together. We really appreciate it here at AMSA.
Great, thank you. And feel free to check out the website, and I put my contact details there in case you want to reach out directly. I'm happy to always answer any questions, or if you want to be connected to anybody, I can do that as well. So thanks so much.
All right, have a great night, everyone. Thank you.
Thank you. Bye.